Um, the second issue is um, there's a lot of work going into how much do we really need clinical visits? And of those clinical visits, how much time has to be with a clinician? So you heard earlier some discussion of that. And so we're looking hard at how you can use EMRs and tablet technologies to take some of that burden away from the staff. So can I give you a tablet that asks you to answer 5 questions about signs and symptoms of acute infection and 2 questions about your adherence issues while you're in the room waiting for the doctor to show up, so that all the doctor has to do is look at it and say, oh, looks like we need to do a PCR for you. I don't like the look of this symptom checklist. The other thing is that some people are saying, somebody said this in the room, why do we need to see a doctor at all? And we're saying kind of conflicting things. So we're saying you need to handhold people and support people, and then in order to get good adherence. And then you're saying, but they don't really need to come to the clinic. They can just call an 800 number in California and do it all on the phone. Well, we have evidence in the literature, not in the HIV literature, but in the other adherence literature, that clinician contact is associated with higher levels of adherence. There's something about having a relationship with a person who's checking in with you and is perceived to be doing it for your health, face to face, that reinforces adherence. So while we want to relieve the burden for the patients to keep coming to the clinics, we're going to have to be creative about how to do it in a way that doesn't affect the thing we're really pushing for, which is adherence and social support. So some people are working in the rural areas, for example, using web-based PrEP visits as a way to get some face-to-face contact, but without people having to come in. There's a lot of discussion about using your local pharmacy for interim visits, particularly where they are already doing HIV testing. So if you have a pharmacy that can do HIV testing, then you can go for your 3-month visit there, get your HIV test. He can let your provider know. If it's negative, he can refill your prescription, maybe under a collaborative practice agreement. So there's a lot of, if there's a minute clinic, you should be able to do the STI testing at the pharmacy minute clinic. So people are doing a lot of work trying to figure out how to reduce patient visit burden. In addition, we've heard from insurers and larger clinics, okay, so we need to have some measures that we're using to determine whether we're doing the right things for PrEP. And so in the guidelines, there is a table of proposed quality of care measures at the clinic level. We've actually made one change to this since the guidelines were written, and that is that the one that says PrEP medication adherence used to just say PrEP medication, and it was just looking at the number of people who were prescribed. And what we think now is much more important is the number of people who appear to be adherent and whose providers are documenting in the medical records that they've assessed that. So we also need to monitor at several levels how well we're doing at getting PrEP to the people that we want to have it. So the question we kept being asked at CDC is, how many people are you talking about? And so last fall, we published this national estimate of the number of people who have indications for PrEP according to our guidelines. And the total number is 1.2 million. That was very interesting to us because the total number of people estimated to be living with HIV infection is also 1.2 million. And so people are always asking us, why are they the same? And it's like, I don't know. They were completely independent calculations. So it's a little under 500,000 MSM. It's a little more than 500,000 heterosexually active adults. and a little more than 100,000 persons who inject drugs. Now, these were all done with adults because that's what the indications are. We then wanted to look, though, and say, okay, so it's good to have a number. Now we have a denominator. But what proportion of people in that population does that represent? So 1 in 4 MSM, in this case, men who have had sex with a male in the previous year, had indications for PrEP. On the other hand, it was 1 in 5 adults who inject drugs, and was 1 in 200 heterosexually active adults. So there's so many more heterosexuals in the population that the number is larger, but the proportion is smaller. So then people said, well, but tell me about my jurisdiction. Well, the numbers that we used for that calculation can't be directly extrapolated. There was a study recently published where they estimated the number of MSM by state and MSA. That was the Gray et al. Publication. So we started with that data, and I just did these for you. So for Delaware, you have 0.3% of all the MSM in the United States, and that's about 13,000 MSM. For Pennsylvania, you have 3.6%, and it's about 163,000. And in the Philly, Camden, Wilmington kind of MSA, you have about 100,000 MSM. So if 1 in 4 of them has indications like it was in the national analysis, that would mean that Delaware needs to offer PrEP to about 3,000 men, and Pennsylvania needs to offer it to about 40,000 men, and the MSA, it's about 25,000 men. So that sort of gives you a target. Now, not everybody, even if you could magically reach all those people, not everybody wants to be on PrEP. So I'm not saying you need to provide PrEP to that many people, but at least it gives you an idea of what order of magnitude you're talking about. So unfortunately, we don't have similar granularity in the estimates for PW, for persons who inject drugs, and for heterosexuals. So what I did in the national data was I said, what was the ratio of PWID to MSM in the national data with indications, and then applied it to these other calculations. And so if you add up all the groups that are estimated, in the MSA, you're talking about 60,000 people. In the state of Pennsylvania, you're talking about 140,000 people, and in the state of Delaware, you're talking about almost 8,000 people. So again, this is order of magnitude. These are all estimates. I don't want anybody even thinking about writing someplace that these numbers represent something that you should target to. But it gives you an idea of how you can use data to come up with locally meaningful estimates. The last thing I want to say is these numbers, on the one hand, are reassuring, and on the other hand, they're daunting, right? So if you say to me, I have to find 25,000 people within our MSM, and offer them PrEP, that sounds like a lot of people. And everybody's in a hurry and wants to get it done fast. I would remind you that introducing biomedical clinical interventions is a slow process. So for the flu vaccine, the landmark trial was in 1968. By 2000, 32 years later, only 55% of people with indications got a vaccination. Pneumococcal vaccine is even worse. Mammograms better. So I think it takes time, and we've been spoiled in HIV because we're used to very rapid uptake. So if you look at New York State, for example, when they looked at their Medicaid data again, you can see that they've had, when they put in place a plan to educate the population, to send detailers to practices, to educate providers, to develop materials, to put posters on transit systems, to make fancy web pages, to issue their own guide. When they did the full court press, they saw a remarkable increase in PrEP prescriptions, and that is continuing to increase since this was published. Gilead looks at national prescribing pharmacy databases, and they saw the same thing, that from 2014 to 2015, there was a 300% increase in new prescriptions. So again, if you're used to diffusion of innovation curves, you expect to have an early initial tail that's slow, and then you get to a place where you begin to ramp up. And that appears to be where we are now. What we would like is soon to be able to see something like this. This is what happened when we got combination highly effective antiretroviral therapy. We got rapid uptake, and we got rapid decreases in mortality. And we would like to be able to see rapid increases in PrEP uptake in the highest risk populations, and measure that it's actually reducing incidence or new diagnoses in that population. In order to help make that happen, we need all hands on deck. And so at the federal level, multiple divisions at CDC are involved in rolling out PrEP. Multiple bureaus at HRSA are involved. The Office of Population Affairs is now doing an assessment of how to implement this, how to gradually implement this in Title X clinics. SAMHSA, both of its centers, the treatment center and the prevention center, are actively engaged in figuring out how to provide PrEP to patients who are injection drug users. And at the state and local level, we're hearing about all kinds of collaborations, some of which are fairly new. So, for example, the HIV/AIDS program and the STD program generally have been talking to each other for decades. And, you know, if there are public health clinics, they're generally linked in. In many places, the HIV program has never talked to the substance abuse program. They just don't, they're in different buildings, they just don't talk to each other. Similarly, the Medicaid program. I can't tell you the number of patients that I would call a health department and say, does Medicaid cover PrEP? And they'd say, I don't know. And I would say, okay, so who would I talk to? I don't know. Same thing about the insurance office. In every program, there is an office that regulates insurers in that jurisdiction. And if you want to talk about coverage issues by ACA or even by private insurers, if you're having a problem with what you think is excessive denials of care, you would normally turn to the insurance office, but most of the HIV programs don't talk to the insurance commissioners in their states. But this has provided an opportunity for that kind of linkage to happen. Same thing with the education department. We had some school-based clinics that wanted to think about offering PrEP to their older adolescents. And they talked to the health department, and the health department said, but we don't manage you. You're managed by the Department of Education. So they had to set up that three-way conversation now for the Department of Education and the AIDS program to have that conversation. Medical associations, obviously, national associations of state and territorial AIDS directors, of city and community health officers, of local boards of health, of STD directors, and of substance abuse directors. All of those organizations are now actively engaged in figuring out how to make PrEP work. So that was my presentation.